services on coronavirus, and I ask the Health Minister to make his statement. Vaughan Gethin.
Diolch, Llywydd. Members will know that I committed to provide regular updates about the COVID-19 developments here in Wales. We can see from the data that, thankfully, admissions to hospital, the number of people in critical care, and the number of people who are sadly still losing their lives to the virus has been falling. We are not yet sufficiently far along the curve to be able to further lift the restrictions beyond the modest and cautious steps that the First Minister announced to the public on Friday, the 8th of May. As you heard, the Cabinet agreed those measures later on Thursday, the 7th. We must remain vigilant and disciplined in supporting the lockdown so we can continue to protect the NHS and to keep people safe. We have been clear in Wales that we must build on the good work that has been done to date, both by members of the public and, of course, by our NHS and social care staff. The stay home, protect the NHS and save lives message is still very much at the centre of our strategy and approach here in Wales, and will remain so for at the very least the next 3 weeks. However, we recognise that there is a balance to be struck between the level of harm that COVID-19 is causing us both directly and indirectly. Now, I issued a written statement last week to alert members of the new operating framework that I issued to assist NHS organisations to focus and plan in Q1. The framework described 4 levels of harm: harm from COVID-19 directly itself, harm from overwhelming the NHS and social care system, harm from reduction in non-COVID activity, and harm from wider societal actions that may flow from lockdown. Now, I want to talk more about the harm from a reduction of non-COVID-19 activity. There are still many people living with serious conditions that need diagnosis, treatment, and ongoing care. We need to ensure that these people have the confidence that they can be treated safely. They need to know that they will continue to receive the same level of care and expertise for urgent treatment, and that it is safe to come in for procedures and diagnostics. Ultimately, though, this comes down to discussions between patients and their treating clinicians, with honest conversations about whether there are particular issues to be considered, and at the end of it all, the patient can, of course, choose to follow or not follow the advice that is given. The reality is that striking the balance between COVID and non-COVID care must and will be done with the utmost care. But the message is clear. The NHS is there for you, and it remains open for business. Now, I want to specifically recognise the harm from a reduction in non-COVID-19 activity for those people who require support from our mental health services during the pandemic. During these unprecedented times, we must ensure that we maintain parity between physical and mental health services. I know that the period of lockdown is difficult for many people, but for some people with mental health issues, it can be particularly challenging. For some, it would have caused their condition to deteriorate at a time when they're separated from their normal support networks, family, friends, and potentially work as well, and when access to non-emergency services will have changed. In response, we've worked with our partners to introduce a range of measures to provide support to those who may need help and reassurance. That includes a tailored online information and access to telephone-based support. A mental health COVID-19 monitoring tool has been developed within the service to ensure that we receive assurance in the government that mental health services are operating safely and responding appropriately. Health boards are required to submit monitoring information on a weekly basis, which are considered by a mental health incident group. The information provides a live picture of the capacity of mental health services to enable us to identify where additional support, advice, or guidance is needed. While service models will have adapted during the pandemic, health boards and partners have reported they have continued to meet mental health needs during this period. Now, NHS organisations will submit their Q1 plans next week, setting out how they can undertake non-COVID-19 activity. To support that work, Public Health Wales has worked together with the Welsh Government and the wider NHS to develop advice built on 3 strong pillars. The need to understand the current infection level and transmission rates for coronavirus in Wales, principles which are both grounded in scientific evidence and address the wider societal and economic impacts, and the need to test, trace, and protect. I'm pleased to announce that earlier today I published our Test, Trace, Protect strategy. It sets out over 7.5 pages how we will work in close partnership with Public Health Wales, health boards, and local authorities to deliver one of the biggest public health interventions of a generation. Working together, we will enhance health surveillance in the community, undertake effective and extensive contact tracing, and support people to self-isolate where required to do so. To support this activity, we will require a testing program of a different scale. We've significantly expanded our testing capacity in Wales over the last week, with laboratory capacity now available to process over 5,000 tests a day, and with testing centres now open around the country. We'll continue to increase this capacity in Wales over the coming weeks and months within the range of 10,000 tests a day. That will enable us to test more people staying in hospitals and care settings together with workers in other critical worker settings. To support our move to mass population testing, we'll draw on the testing programme operating across the UK. Now, NWIS, our NHS informatics service, are working with Public Health Wales and NHS X. That's the joint unit that brings together teams of the Department of Health and Social Care in the UK government and NHS England and NHS Improvement to help deliver digital transformation and care in England. They're behind the development of the app that people have heard about in the Isle of Wight. Working together with NWIS and Public Health Wales, they're developing a data solution so that test results will be reported electronically back to Wales on an hourly basis. And that now means we can take our population share of the UK testing programme. It is crucial that this test record is able to be integrated directly into Welsh clinical record systems. Participation in the UK programme will significantly further increase the number of tests available and allow people to have tests delivered to their home for them to self-administer. In total, we could require as many as 20,000 tests a day to support diagnosis and treatment, population health surveillance, contact tracing, and business continuity. That will, of course, enable key workers to return to work more quickly and safely. It would also, of course, depend upon the progress not only of coronavirus, but our phasing out of lockdown and further activity for members of the public. But this number is highly dependent on the spread of the disease, the prevalence of symptoms, and the emerging evidence on how testing can best be deployed to prevent further infection. We'll continue to keep that evidence under review and to adapt our estimates of need accordingly. Combining our own capacity here in Wales with that of the UK puts us in a strong position to test as needed. We have to learn to live with the virus that is circulating in our communities for many months to come. Adopting this approach is a way in which people can be told quickly of their exposure to the virus so that they in turn can limit their exposure to others. This will help us to prevent infection and track the virus as lockdown restrictions are eased. And finally, the people of Wales are our most important partners. It is only through their willingness to do the right thing, to report their symptoms, to identify their contacts, and to heed the advice when told to self-isolate that we can break the chain of transmission. I want to thank the public for continuing to support lockdown arrangements. I've been reassured by the response both from those within the NHS, social care, policing, and indeed the general public. They support the cautious and realistic approach that we're taking, and it's been widely welcomed. I don't doubt for a moment, though, that it's difficult to continue with the restrictions that have been imposed. However, keeping these extraordinary measures in place, together with that widespread public support for them, remains a single most important factor in protecting the NHS and keeping our family, friends, and loved ones safe. And more than that, it makes the biggest difference in keeping people safe who we may never know and may never get the chance to know. Joch, I'm happy to take questions on the statement, Llywydd.
Angela Burns.
Diolch, Gareth. Minister, I'd like to welcome the statement, and I am pleased to see the Test, Trace and Protect initiative being launched today. However, I do have concerns. As you know, I would have put a dedicated team with a very visible lead into place, and I'd be really grateful if you could tell me whether or not you do have an entire department or group who are literally focused on this, because it's so important that we get testing right to ensure access for all, to ensure prompt delivery of test results, to show that everyone has the same ambition and targets. And as we heard from the very shambolic evidence given to us by the head of Public Health Wales, there was a distinct divergence in targets between Welsh Government and the Public Health Wales ambition. We need to ensure appropriate laboratory capacity to ensure the data and results get to the right people. And we need all of this because we need to get safely out of lockdown. So, are you confident that Public Health Wales will be capable of managing the Test, Trace and Protect programme? Your ambition to have 10,000 tests, you don't say by when, it just says over weeks and months. And is this an actual target? And is it a target that all of the people working within the health services cleave to? In terms of health surveillance work by Public Health Wales, are you confident that this will be able to be done in an accurate way, given the problems we've had over the last few weeks with data coming out of health boards? In terms of the contact tracing element, have you more thought about how many people would be needed to do this? You talk about 1,000, and I note that Scotland want about 2,000 for a population of 5.5 million to our R3. I mean, is that what you're basing it on? I'd be interested to know that, because we know how difficult it is to get people into the right roles. And are you really confident that NHS Informatics, not necessarily the most stellar organisation, are able to deliver a single digital platform for contact tracing in the time required? Will you be able to, can you tell us now that once you've put the proximity tracing in place, will the follow-up after the proximity tracing being the same? And finally, on this suite of questions, may I ask about the protect element? You talk about people having to self-isolate maybe in multiple times, absolutely understand that and the reasons why. But what support will be put in place for those people? Because if they've got caring responsibility, children trying to go to school, if they live in an environment like a big block of flats, they may constantly be asked to self-isolate, and this is going to damage their mental health even further.
Minister.
Thank you, Lewis. Thank you to Angela Burns for the series of questions. I'll try to go through them briefly. Yes, we do have a director, a senior civil servant who's been empowered with oversight, not just within the government, but the Welsh Government needs to coordinate and lead the system to make sure that the Test, Trace, Protect programme actually works and that everyone buys into it and understands the varying roles and responsibilities the different parts of our system will have. And so that's going to draw together right across not just Public Health Wales, but our other trusts, our health boards and local government. And that is working well. And I've been really encouraged by the way that health boards and local government have been working together on the planning phase for wanting to move ahead and to deliver this programme. But Public Health Wales won't be managing the whole programme. They provided lots of the ideas and some of the clinical oversight. They provided the public health evidence about what we need to do in overall terms. This is now the operational end of it, and they're not going to lead the operational end of the system. That's again why we've empowered a senior civil servant to lead that, to hold the ring, and of course I've got ultimate oversight for what is taking place. On the 10,000 or so tests we expect to have, I want us to be able to be in place for the end of May. That's set out in the Test, Trace, Protect document. That's when I want us to have that sort of capacity in place. As I say, that's a combination of the capacity we already have in place in Wales, together with a share of the UK-wide arrangements. So I've got a reasonable measure of confidence that will be in place for the end of May, when we want to be able to potentially roll this out on a wider basis. But our use of those tests, of course, will depend on where we are and the amount of circulation that is taking place from the public. If there's a further release in lockdown measures, people circulate more freely. There's a potential for more context, even with the social distancing rules in place. So at each stage, we may need more tests, and in particular, as we get up to the autumn period of time, where flu and colds and other illnesses that are often like coronavirus symptoms are in wider circulation as well. And that's where we've got to forecast and anticipate a change in demand. That also comes back to your point about staff as well, because the initial figure in the document of 1,000 staff, that comes from plans that health boards and local government are already working together on. And I'm really grateful for the way that the local government family across Wales of varying political leaders have worked together with health boards on planning for this. And we're making use of the resource that exists in local government, the staff who aren't necessarily at work. Some of them want more things to do, and this is an area we can help those people to work, and including people in their own homes, depending on the digital solution. So that's the initial point. But again, we may not need 1,000 people sat waiting for calls on the 1st of June, but that's a figure that we're working to at the sort of staff numbers we're going to need. And you're right, it is a rough approximation of the numbers in Scotland, but we'll have to judge the evidence on the extent of the programme and what we're going to need and whether we need more people. And that's an active conversation that local government, the health service, and indeed my officials are having. On your point about NWIS aren't looking to build their own system within a few weeks. It's actually about what they're procuring and the work they're helping to lead on, but to make sure that that digital system works and is able to integrate with other systems we have within Wales. So they've got a really important role on helping us to get that right. It's also important, I think, to recognise what I said earlier about the UK government testing programme. We're now in a position where the data transfer issues are being resolved, and that gives me a much greater amount of comfort, because previously we could have had tests but not understood what the results were, so the utility of them would have been really, really limited. We're now in a much better position, and so that will be useful. We want the same issues from the NHS X app that's being developed as well, because if it works, if we resolve all the privacy issues about who owns the data and how it's resolved, and I think we're in the right sort of place on that, then that will help us in terms of contact tracing. And if that works from the trial, then I'd want Wales to be able to take advantage of that. But again, to make sure those data transfer issues are resolved. On the conversation with local government and the wider voluntary sector on supporting people, then that is a conversation we're starting. I've had a very constructive series of rapid conversations, and this is an extremely rapid development of policy and putting it into action that we're undergoing. But they recognise, as we do, that if we're going to have a group of people that are being supported now and they go into further circulation, doing more things in the future, if we then ask them to self-isolate again, they'll need to be supported. We need to have mobile teams around those people who may need to isolate more than once. But the purpose of this really matters. There's harm caused by being in lockdown. There's potential harm being caused if we ask people to self-isolate again in the future. But it's to balance that harm. And as you heard in the First Minister's statement and questions afterwards, if the R value goes up to 1.1 over a 3-month period, that's thousands of extra deaths that will take place in Wales. And we have to bear in mind that difficult balance we have to take. But I certainly won't take a cavalier attitude that could potentially risk the lives of thousands of Welsh citizens. And I would, of course, continue to keep members updated.
Angela Burns.
For that. And so just for clarity's sake, I want to confirm that it's 10,000 tests by the end of May, because your document says we will continue to increase this capacity over the coming weeks and months, potentially to as many as 10,000 tests a day. And I think we just need that clarity, given the shambles we've seen over the last few weeks. I'd like to just turn quickly to non-COVID harms, and particularly to the diagnosis and treatment of critical conditions such as cancer. You mentioned the non-COVID harms in your statement. Now, we were already behind on so many metrics before the pandemic. People are contacting me because they need investigative treatment, they can't get it, they think they have cancer, or they've been told they might have cancer, they're really worried, and they see that hospitals are under less pressure than we all thought that they would be. And so these people are suffering excruciating mental torment, not sure what's going on and when they can get that treatment. I understand that health boards are working on this, but when will services start? Can you give us a rough time frame? Are we talking a couple of weeks or a couple of months? And can we restart the screening programme, such as breast cancer? Because that's not hospital-based, that's a mobile unit. Can we use the mobile units of organisations such as Tenebus to actually give and to administer treatments? Because, again, those kind of areas should be easy to keep as green zones. What plans do you have to cope with the backlog, and how do you plan to engage with the public to get them to come back into these vital services for the treatment that they so desperately need?
Yes, thank you for the follow-up questions. On cancer, actually, we had better waiting times relative to England before lockdown took place. And of course, we also introduced the new single cancer pathway, which is a more honest measure of waits within the system. And it's been widely welcomed both by clinicians and the campaigning third sector. So actually on cancer, we were in a relatively a better position in many ways than over the border in England, particularly given the fact that Wales is a poorer, older country. You'd normally expect cancer outcomes to be markedly different and more adverse in Wales. So actually, we were in a better position at the start, but I don't want to lose sight of the fact that there are some people who are not coming into our cancer services, even when there's an urgent need. But cancer services never stop. The urgent need never stopped. What we've seen, though, is a drop-off in some of the referrals in and a drop-off in the number of people attending. And that is a choice that people are actively making, because I've had conversations with NHS chairs and chief execs where they've had their clinicians actively speak with people to try to reassure them that the system is safe to treat them, but people are still fearful and are pausing or postponing their own treatments. Now, that's part of the point about wanting to keep on reassuring the public that we're doing this work. We want people to come in, and in the wider restart of our system, including screening services, it is actively under consideration. The things that I'm looking for, just as members are as well, because those urgent care need that has been paused over a period of time, well, that is building up need that isn't going away of its own accord. And that's why the operating plans for the first quarter will be important. And I fully expect to update the Chamber and the committee again on those plans as they're being developed, because in terms of the balance of harm, it's one of the things that I've been particularly aware of and concerned over the past weeks on the figures and information that we've seen. So I can give you a very clear reassurance that urgent cancer care services have not stopped. They're still available today. We want people to use them, but we need to build the confidence of the public to use them, which I think was Angela Byrne's final point. And that's why I think statements from myself, from the NHS Wales Chief Executive, and indeed clinicians across the country encouraging people to use our services will be really important in a consistent way to rebuild public confidence, to make sure that this treatment really can make a difference in limiting harm in the future, that people have the confidence to come and use them, because NHS, as I said in my statement, is open for business.
Rhina Bjorwerth.
Diolch, Llywydd. I'd like to start with the Test, Trace, Protect document and thank the Minister for its publication. It's useful because it adds to our sum of knowledge about what government is trying to achieve. But I think a detailed plan for testing, tracing and isolating was long overdue, and I think it remains, unfortunately, long overdue. What we have here I think is largely a statement of principle that few would disagree with in reality, that having a test and trace strategy is vital in the battle against coronavirus, that it will need to bring lots of different partners together to deliver it. We all surely hope to be able to start moving towards, significantly lifting restrictions, in the not too distant future. That's what we all hope for, but we can't, start thinking of significantly lifting lockdown restrictions before we have a robust test and trace plan. And I don't think this can be described as anything like a robust or comprehensive or detailed plan. So we'll wait for that. the document mentions, as we heard, potentially the need for 10,000 tests a day. It's clear on that, double the current capacity that we know has taken a very long time to reach, yet Public Health Wales suggests the range of numbers of symptomatic people you may have to test is between 7,500 and 17,000. Surely that's what we should be aiming for. There is reference to 20,000 later in the paper, but it's very unclear from the document what that refers to. I think you may have made it a bit clearer in your oral statement, but in terms of the document itself, it's very unclear. It's not just about the numbers, it's about how you process those tests and go about the tracing. You talk of easy and rapid access to testing. How quick do we need? How rapid does it need to be in order to be effective? What's the local level of access to all our communities going to be to this, given that we only have a certain number of mass testing centres? A strategy at the end of the day is only as good as the implementation plan that we need to put it into action. And there's no detailed plan here that I can see to put the already widely accepted principles into practice. So when can we expect that strategy that we have to turn into something that can get us ready to actually lift restrictions, not just talk about it in abstract terms?
Minister.
Well, in terms of the strategy document, it's similar to the strategy document that Scotland published in the sense of it's a public-facing strategy document to give an explanation of the strategy we're going to follow and about what the ask is of the public and how our whole system is gearing up to deliver that. There will, of course, be a detailed operational plan that's in development between the different parts of our service, and we'll learn more about that as over the next week. At some point over the next week, we'll have health boards and some of their partner local authorities looking to trial some of the contact tracing element of it, with a particular focus on the care home sector. And there'll be lots of learning to take from that. I'm expecting to have confirmation of the particular pilot areas, if you like, in different parts of the country that are going to move forward. And that again comes from the work that health boards and local authorities are undertaking themselves. There'll be lots of learning over that trial period before we get to the end of May, not just in those pilot areas, but to deliberately share across the rest of the country. So actually, in a really brief period of time, we've had lots and lots of development and real progress. We'll have a trial that's going to start in different areas next week. We'll have learning that comes from that. And of course, I expect not just in terms of confirming who's undertaking trials, but then the learning from those as we build towards having that more detailed operational plan in place. So all the detail about the scripts that the tracers will need to use and the detail that you'll find, you expect to find those documents available in the service together with the training for people. This document, though, is a public-facing document that says this is the strategy we're going to take, this is the approach, here are more of the numbers following the leaked draft reports that people discuss. We now have more finesse and understanding across our whole system, what's needed and how we're going to go about it. And in terms of your point about local access, well, that's why we've got mobile testing units. It's also why our ability now to take proper use of the home testing service is really important, because it's UK-led, but there's been signed up an agreement from all countries in the UK to make use of that home testing service. And that will mean that our reach in remote areas of the country, and they exist in rural, semi-rural and urban Wales as well, will be increased. So that's a really important step forward. And again, the point I made in my statement really does matter. To have the ability to have the results of those fed back into the clinical record to make the maximum use of it, I think will be really, really important. Of course, that will make more of a difference when we have a reliable antibody test. We're able to deploy that within our system.
Os bydd y gweinidog wedi crybwyll yr sector gofal yn fyna, dwi am droi rwan as gartrefi gofal. Mae'n bryder gwirioneddol gen i bod camau cryfach ddim yn cael eu cymryd i warchod y sector yma, sydd wrth gwrs yn wynebu risg mor uchel. Mi fydd y gweinidog yn gwybod mod i o'r farn bod angen i'r Llywodraeth gael cynllun i mestyn profi asymptomatic i gynnwys pob cartre gofal, beth bynnag i maint mae'r dystiolaeth yn gry iawn ar hynny. Ond mae eisiau edrych ar sut i gau y drws i'r feirws gyrraedd cartrefi yn y lle cynta. Dwi'n meddwl dwi'n dwi'n dal i gael pobl yn deud wrtha i yn y sector gofal i bod nhw'n hynod bryderus am bobl sy'n cael eu rhyddhau o'r ysbyty ar ôl triniaeth i gartre gofal, efo'r posibilrwydd wrth gwrs o ddod â'r feirws efo nhw. Mae yna dynhau ar y profi sy'n digwydd, mae'n rhyfeddol nad oes na brofi automatig o'r dechrau ar bobl oedd yn cael eu rhyddhau o ysbytai i gartre, ond mae eisiau mwy na hynny. Fydda'r gweinidog yn cytuno efo fi bod angen rhoi camau mewn lle mwyn sicrhau mur, quarantine os liciwch chi, rhwng yr ardal honno alla fod yn risg, sef ysbyty a'r cartre gofal, a bosib rhoi 7 diwrnod o gwarantîn i berson cyn mynd yn ôl i'r cartre gofal. Yna mewn rhan gwyrdd o ysbyty, mewn gwesty hyd yn oed, mwyn wneud yn siŵr bod ni'n cau y drws y gymaint y gallwn ni'r risg bod yr feirws yn cyrraedd cartre gofal, achos da ni'n gwybod yn iawn bod i'r peryglon unwaith mae hynny'n digwydd.
Minister?
Yes, thank you. As I've said before, and I guess I'll have the opportunity to say this on every single occasion I come here, when the evidence changes, if the advice changes, and the government will be happy to reconsider its position on any of the areas of activity we're undertaking. That includes the developing evidence base on asymptomatic testing in care homes. We made a move on changing our policy on testing across a whole care home environment. You'll recall a couple of weeks ago for areas where there was either a confirmed case or a suspected case where someone was symptomatic. And so we'll learn more from that about asymptomatic testing, the likely prevalence, and also the value and how we deploy our testing resource and the value we expect to get from that. And it's really important to understand how we use in the best way to keep as many people safe, well, and alive as possible. So again, if the evidence does change, then I'm happy to move, and I'm certainly not looking to be stubborn and dig my heels into the ground on any of these issues, because it's all got to be their overwhelming priority and purpose, which is about keeping people alive and well. That's about on hospital discharge. We've introduced a policy where there should be testing on discharge in hospital before they go to care home. If members in any group are aware where they think that isn't happening, or have got cases that people have come to them, you should take that up with the health board initially. If there isn't an appropriate response, then by all means contact my office, because I would want to know if those issues aren't being addressed in accordance with the ministerial decision on this that I have already made and communicated. The points about quarantine are rather more difficult, because again, we need an evidence base on where the value is of that, because the member and others will know that the phrase quarantine is probably unhelpful, but I understand what the member's trying to get at. But if you're going to hold people in an environment, what environment is that? Are you still making sure that people are mobilized because no real harm is caused where people are kept in an inappropriate environment? Well, hospital is no longer the right place for someone, especially older people. Then real harm can be caused, not just healthcare acquired infections, but also physical deconditioning as well. When we talk about the harms that are caused, what we don't want to do is ignore that harm that really can be caused, and the wider social harm that can be caused by people becoming deconditioned and losing their independence as well. And what I don't want to do is to fill up all of our field hospitals as centres where people are held before going back into the care home sector, where there's a proper national conversation on how we make use of that capacity. What I would not want is that we potentially have a further rise in coronavirus in September and our field hospitals are then full of people who could and should be in care homes. We need to understand the evidence. We need to have a conversation with all parts of our system. That includes local government and people like Care for in Wales, who represent many people within the care homes, that understand what the right answer is, how we build confidence in the system, how we understand the different harms that can be caused by making different choices. So it's not a closed door response, but I do think we've got to think about what that evidence looks like. And there's already a conversation that I've asked for to take place between health and local government, and then to draw in our colleagues in Care for Wales to understand what that could and should look like.
Caroline Jones.
Minister, on Monday night, many of us watched the heroic actions of the ICU staff at the Royal Gwent as they battled to save the lives of those infected with COVID-19. It was both truly heartbreaking and heartwarming at the same time. It brought home the sheer horror of the disease, and it highlighted the fantastic levels of care and compassion of all the staff working in our critical care departments. And we simply cannot thank them enough. They went through hell to save lives, and the least we can do now as a public body is to stick to social distancing rules. Minister, thankfully, we seem to be over the worst of the outbreak, and according to the modelling update provided by the Technical Advisory Cell, the number of cases are halving every 10 days or so. However, history tells us that pandemics come in waves. Minister, we were woefully unprepared for the first wave. That was no one's fault, but we have to learn lessons. So what steps are you taking to ensure that we are fully prepared for future outbreaks of this or any other pandemic? We must also ensure that we are not prolonging the current outbreak. And I was contacted by a constituent yesterday whose elderly mother was sent home after being told that she probably had coronavirus. This lady was sent home to spread the infection onto her family and carers. My constituent is still extremely unwell and is aged 79. Minister, why aren't we testing everyone leaving hospital to ensure that we are not adding to infection rates? Minister, there is emerging evidence of a strong correlation between vitamin D deficiency and COVID-19 mortality rates. Given this and the evidence that the risk of spreading the virus is much less outdoors, shouldn't we be encouraging people to spend more time outdoors, provided they stick to the social distancing rules? Remembering that not every family has a garden for children to play in, and whilst also noting at the same time the rise in cases in Germany after relaxing some of the measures. Minister, our whole approach must be a balancing act, and the harms of coronavirus have to be weighed up against the harms of strict stay-at-home orders. So can you give us your assurance that tackling the harms associated with loneliness and isolation will be a key factor in the Welsh Government's approach going forward? Will you also outline a timeline for when our NHS will be open for all patients and not just those with life-threatening illness? And as ever, I thank you and your department for all the efforts in the fight against coronavirus. Diolch yn fawr.
Thank you for questions. I'll try to get through them as quickly as I can, Llywydd. On pandemic preparations, we'll have lots of lessons to learn on the back of this. Our primary preparations were for a flu-style pandemic, but this is a slightly different form of pandemic. We'll have lots of lessons to learn. We're learning as we go, and the way that we're not just stocking but restocking our personal protective equipment stores is part of what we're doing in the here and now, but we'll definitely need to take a look back ourselves. And as I said before, I'm sure that in every parliament across the United Kingdom, there'll be a desire across party to look back on what's happened when we finally reach the end of this, to learn lessons, to understand what we did, but crucially, to understand what we need to do for the future. And I hope that inquiry can take place sooner rather than later, because that would mean that we're actually at the end of the coronavirus pandemic. But I do appreciate that is going to have to wait until we really do reach that point in time. On the point about testing every hospital resident, I think from the example you've given, if they were symptomatic, as you suggest, then that's the sort of thing where there should have been a clinical view on that and a test offered, if appropriate, before they left. And again, I think that's the sort of thing to take up with the health board directly. And if you don't get a satisfactory response, then do come back to me. We are, as I said, in response to Rhiannon John, we're continuing to review the evidence on what we should do. And that may well change what we need around testing of both hospital patients, but also of our staff in health and social care as well. In terms of spending more time outdoors, well, we changed the regulations in Wales. One of the modest and cautious easements we made to the lockdown regulations and approach here in Wales was to say that people could go out for exercise more than once, because the evidence the First Minister referred to about the fact that the half-life of coronavirus is significantly reduced outside and in sunlight. So that's a change that we have made to encourage more people to go out more than once a day for exercise. And until your point about loneliness isolation, it's been a point that ministers have considered each stage in the changes we're making, and it's a matter of real concern. There are many members in the chamber who I know, like me, have older parents who they are effectively caring for. And it's something that bothers me about my own family. I know other members take that seriously too as well. And so the strategy for alone and isolation is part of the support we put in place that we funded, especially with the third sector, to provide support, and will absolutely be one of the key factors we need to consider in terms of exiting lockdown and the eventual path to and through recovery. And in terms of timeline for further NHS activity, I should be in a position to provide a better idea about that, as I both received the plans on Q1 and as I've indicated, I think in response to Angela Burns, that I do intend to bring back a further statement to give some more detail on that. And I believe I've had the pleasure of an invite from Dr. Lloyd to return to the Health Committee in the next few weeks as well. So there will be opportunities for me to set out where the NHS is and to face questions from members on that.
McAntonev.
COVID-19 related inflammatory disease which affects children in the UK and indeed other parts of the world. Will the Minister give an assessment of the risk to children and young people in Wales and update us on any action taken by the Welsh NHS? And could you also confirm that any evidence that emerges in respect of child-specific COVID-19 illness risks will be factored into the decision-making process in respect of school reopenings? And can you also comment on reports that in England, the UK government is recruiting unpaid volunteers working alongside paid workers to carry out COVID-19 tests? Do you agree with me and with the trade union Unison that this really takes the notion of volunteering way too far? So will you be able to confirm on behalf of the Welsh Government that those contracted to carry out testing in Wales are properly trained, properly provided with protective equipment, and they are being properly paid whilst carrying out this work?
Minister?
Thank you, Mick. And I think it's important to acknowledge that members may or may not have seen reports of an inquest has opened today of a very young child who's passed away after their mother passed away, with COVID-19 being, I think, the primary cause of the death of the mother. And whilst not the primary cause of the death of the very young child, I think a child of just a few days old, the general evidence is that despite the tragic circumstances that are being resolved by the coroner there, the general evidence still is that younger children have a different response and are a lot less likely to come to harm. That doesn't mean, though, that we should be cavalier about our approach to young children and their care and treatment. And it's why this government is taking a properly cautious approach to school opening, because we don't fully understand all of the evidence about the transmission both between children and between children and adults of this particular virus, because there was real concern at the start of this. You could potentially have children mixing with older grandparents, where people in a lower risk group could be mixed with people in a higher risk group, and you could end up transferring harm. And it's been one of the really difficult parts about this, I know, is that grandparents who aren't able to see their children. And I know that there are grandparents in the assembly, but we've all got constituents who feel some of that real pain and difficulty in not being able to see their family. But the school reopening will have to take account of the developing evidence and the developing understanding of the impact upon children, but crucially about the behaviour of adults around school openings as well. Because actually, if children themselves are less likely to come to harm, you still need to think about the staff and how staff mix if they're going back to a school that's been reopened. You also need to consider about parents dropping off and collecting, in particular, in a primary school environment around a school gate. So we've got to think through how all of that could work, but we're not at the point where that decision is being made in Wales. But I can give you the assurance that you're looking for, that the evidence will definitely lead to and inform the choice that the Welsh Government makes. And when that choice is made, you'll hear from our Education Minister first. On your point about volunteers and the testing programme, I'm happy to confirm that our approach in Wales is not to ask people to undertake voluntary to either administer tests or indeed to undertake the contact tracing that we've been discussing earlier today. Where it's paid work, they should be paid, and the appropriate conditions for that employment adhere to, including if there is a need to wear PPE. So that's not the way that we're looking to roll out the service here. And, you know, it's for England to explain what they're doing in England, but the approach we have here in Wales is that you can expect paid staff on proper terms and conditions to do that work.
Janet Finch-Saunders.
Yesterday, an email from the Welsh Government detailing the criteria for the extra £40 million for adult social care announced on the 14th of April advised that eligibility is limited to local authority commission care only. So I therefore query why care homes with NHS or privately funded clients have been excluded. Now, because of this amended guidance issued only by email and not published, as has been mentioned by the Welsh Government, one local authority has just this morning asked their nursing homes to clarify which of their PPE is used for social care and which is used for nursing purposes. I find that to be outrageous, Minister. And during last week's plenary, the First Minister denied my claim that local authorities knew nothing as yet about the £500 bonus for carers announced on the 1st of May and how it will be distributed. I have had it confirmed very robustly this week that no criteria or guidance has been issued. So when will this be the case, and when will this money actually reach the pockets of all our valuable social care workers? Diolch.
Okay. On the £40 million, it's been issued to local government to support the social care sector. I would expect that those people that have care commissioned through the National Health Service will find they're having the appropriate support for their businesses as well. I'm happy to take up a further conversation with it, and I know that our lead director here on social care and integration is having that direct conversation with the Welsh Local Government Association, with the Associate Director of Social Services, and I expect that's a conversation that should reach a proper conclusion. We also have regular engagement between myself and the WLJ, and of course there's a regular 3 times a week, I think, leaders call from all 22 leaders with the local government minister. There are opportunities to have those conversations to understand how we use that money. I also think it's really important to recognise that this isn't a one-shot. We're going to be in these extraordinary circumstances for months to come. And we need to make sure that the calm and rational, at times searching conversation we need to have is a way that we deal with this rather than making rather more extraordinary claims. On PPE, I'm not sure that I really understood the point that the members make. It seemed to be confused about whether or not local councils are asking about how PPE is used for nursing or non-nursing care, or whether it's about the provision. But ultimately, the government is paying for all of that. We're paying for PPE that is distributed to nursing homes. We're paying for PPE whether people are receiving nursing care or not. In normal times, we wouldn't be doing that. It's another mark of the extraordinary times that we're in. The fact that the government is providing that care to employers who have legal responsibilities for PPE, but it's the only way to make sure that adequate PPE reaches our frontline members of staff for where they're actually providing care for our constituents. And on the £500 payment, there are ongoing conversations and negotiations about the terms on how that payment is made to people delivering frontline social care. And I welcome the fact that the member wants to see people have that in their pockets. I hope she'll join with us in asking the UK government to make sure that's provided free of tax. That would be a welcome bonus for these relatively low-paid members of staff, and I hope that her and her group will lobby the Chancellor and the UK government to make sure that happens, rather than seeing some of that money snatched away in the form of tax and national insurance. But it's an active conversation between employers, trade unions and the government about how the detail of that should be worked through, for example, to make sure that a one-shot payment doesn't compromise in-work benefit payments for some of these members of staff. I wouldn't want to see these people penalised for a real gesture of recognition of the extraordinary times that these members of staff are living with and the care that they're providing in each and every one of our communities.
Guy Lloyd.
Diolch, Llywydd. Gweinidog, rhestrir gweithwyr Llywodraeth leol a chenedlaethol yn glir fel gweithwyr allweddol gan Llywodraeth Cymru gyfer polisi profi Llywodraeth Cymru. Serch hynny, da ni wedi clywed am enghreifftiau o weithwyr y DWP yng Nghymru yn cael eu gwrthod rhag derbyn profion Covid. Mae yna adroddiadau bod y DWP ei hunan yn dweud wrth i staff sydd yn gweithio yma yng Nghymru i fynd i fristau i gael prawf. Felly gall y gweinidog gadarnhau y bydd yn sicrhau bod gweithwyr allweddol sydd angen prawf Covid yn gallu cael un yma yng Nghymru, gan gynnwys y sawl yma yng Nghymru sy'n gweithio i adrannau Llywodraeth sydd heb eto wedi ei datganoli i'r Senedd hwn.
Gweinidog.
Well, I won't drop the invitation that the member has given to get involved in the wider constitutional debate about which departments are or aren't devolved, but I'm aware of the issue at both the DWP and also the DVLA, and those issues are being addressed. If the member still has people coming to him over towards the end of this week who are saying the issue hasn't been resolved, then I'd ask him to write to me, because it's a matter, like I said, that I'm aware of and is being addressed with both the local health board and indeed Public Health Wales.
Heaven David.
In my discussions with public health bodies, a figure of 3,000 staff have been identified to make the trace system work. The latest figures I've been given is that for every one person who is identified with the virus during the tracing process, a further 20 to 30 people would need to be traced. You've said that staff will come doing that tracing will come primarily from local authorities. So can I ask, from what kind of jobs should the staff be doing this work be deployed? What training and expertise will they require? And who will design and deliver this training? And are you confident the staff can be found in sufficient number?
Okay, thank you. In terms of the numbers, we've updated the numbers from the initial draft that Public Health Wales provided. That's why we get to the figure of 1,000 that we published today. That's the reason, but as I explained earlier, you can expect the number to move around. And that's part of the challenge here, because when we start, if we're going to start from the 1st of June for the sake of argument, then we may not need everyone in that full 1,000 at that point in time. We need to have enough people trained though so the system is robust. And actually Public Health Wales are working with the rest of the system to make sure that the training is what people need to be able to do, how they run through that, and the scripts they'll have to use, and then how they then need to record that information. That's all being worked through, and you'll see the trial of that. Some of the trial of that, at least next week, will help to inform and I think further advance that work. In terms of not just the numbers, but where they're coming from, local government have been really keen to play an active part in this because they already have people who have got IT skills, who are used to using IT as a regular part of their job, who are keen to have work to do. They're really committed public servants, even in their specific area of work they were doing before lockdown. And because of lockdown, some of those activities aren't taking place as well. So there are people who want to be redeployed, who want to work in this area. Now, that means we've got a group of staff, the Welsh Local Government Association, again, across all different political leaderships in different parts of the country, say that there are enough staff to meet the need that we'll have for that, if you like, that contact tracing team. And so we're relying on the detailed conversations that are taking place there. But there will then be a challenge, as if we are able to successfully unlock further areas of activity over a period of months, what that means in terms of financial pressures, but also then if other areas of activity are returning, but how we make sure that we don't suddenly lose staff who are working in this way, but to make sure that the whole system is still robust and can effectively work. And those are things we're continuing to work through with local government, but I really do think for the first stage of contact tracing, it'll be essentially a local government resource who'll do that in partnership with the local health boards. And I do have a good measure of confidence we'll have enough staff to make this work. And we will, of course, need to address a range of challenges to make sure those staff are still in place in the right number in the months ahead, because we're talking about many, many months of a contact tracing system in place where the test, trace, protect model will need to be active right across Wales.
Neil McAvoy.
Llywydd. Diolch, Llywydd. Minister, could you tell me what testing is being done in Wales of prisoners before they're released back into the community, please?
That would depend on the referrals made from the prison service. And it's difficult because when they're within the prison service, they're in a non-devolved service. And then if they're going to leave, they'll very quickly come in contact with, in the great majority of cases, with devolved services, whether it's housing support or whether indeed it's social care needs that a number of people have. You think about the prison in Usk, a lot of those people are actually quite old and they have a range of care and support needs. But the testing should be in accordance with our broader testing policy, whether people are asymptomatic, and of course that goes for staff as well.
Aaron Miller.
Thank you, Llywydd. Can I ask you, Minister, one of the issues that we went into before this pandemic was that on the agenda of many local health boards was the prospect of significant reorganisation of some of their services. Now, obviously, because of this particular crisis, many health boards have frozen their plans and aren't progressing with them, understandably. But you may be aware that the Betsy Cadwaladr University Health Board is due to look at its vascular services and was due to receive a paper at its health board meeting this week. Now, I'm pleased that they have deferred consideration of that paper because it was not published within sufficient time to meet the governance requirements of the board, i.e. before 7 days in advance of the meeting. But can you tell us, will you reassure the public that there will not be significant reorganisation of services done in the background while we're dealing with this crisis, in order that all of the energy of the health service can be focused absolutely on dealing with what is the major challenge at the moment, which is COVID-19?
Well, the health service has been reorganised effectively to deal with this major challenge. We were talking earlier about some of the challenges of non-COVID harm that are taking place, because we've had to refocus our whole service, the way we scale up different parts of the service, from creating a field hospital to the extra critical care capacity we've got. So the broader reform agenda that Healthier Wales set out has obviously had to be largely paused. But as we return to having more activity, we're still going to need to consider how we operate effective services in this changed environment and what it means for the future. But I would not expect that there would be new and radically different proposals that be introduced. It's rather difficult to engage and involve staff in those, or indeed the public. The caveat that I think we do need, though, and we all need to be grown up about this, is that there could be changes to services that have to take place from a patient safety point of view. And what I wouldn't want to do is that we would want to say that that could not take place because of the wider pandemic. But if there's any idea that change would be sneaked through or pushed under the radar, that isn't going to happen. But more than that, though, we will need to think about how we take forward some of the things that have happened. So, for example, the changes on greater use of technology, the opportunity to reform outpatients. There'll be a range of things that we will want to do and not simply go back to, in every aspect, the way things were before. But on vascular services, for example, I certainly don't anticipate there being major change, but that will be a matter for the board with the paper that they consider and the review that are already instituted and put in place.
Dalith Jewell.
Research published this week from the ONS shows that people living in poverty are more susceptible to catching COVID-19, no doubt for a variety of reasons relating to poor housing and the likelihood of there being in jobs where socially distancing is not possible. People living in poverty are also more likely to have medical conditions that make the virus more severe. Now, I represent an area where poverty is particularly rife, so these numbers were really sobering. Minister, none of the factors that have led to this poverty were inevitable. They're the product of political choices of governments that have condemned some sections of society to an increased risk. If poverty were treated with the seriousness of a national security threat, it wouldn't have been allowed to proliferate. But it does undermine our biosecurity. So I'd ask you, Minister, what assessment you make of this link between poverty and the deaths from the virus, and what steps your government will take to counter this scourge of poverty that's risen over the past 20 years. What measures will you take to reduce the R rate in poorer areas?
Thank you. Well, it's no surprise to me that people who are the least well off in our country run the greatest risks in terms of their health. There's a direct relationship between poor health and poor economic outcomes as well, that don't match the talent that exists in those communities. And I see that within my own constituency that I'm proud and privileged to represent. It's a picture that many of us in the Assembly will recognise. So the challenge of where you have poorer ill health outcomes to start off with, and then having widespread communal spread of COVID-19, and then you have the overlay of how closely people live together, people's inability potentially to travel to work in their own car. I represent one of the parts of the country which has one of the lowest levels of car ownerships. There are different challenges people face in how they live their lives, but it also reiterates the importance of the the test, trace, protect scheme that we're going to be introducing across the country. It's about protecting people from that harm that would otherwise take place. It's the importance of the social distancing rules. The further people adhere to that guidance and those rules, the more likely we are to prevent harm from taking place in any family or any community. And I can honestly and absolutely say that for this government, the achievement of social justice drove us and government supporting backbenchers into politics in the first place. It's the reason I gave up my other job to stand for election. It's the reason I joined my political party, and is right at the centre, the reason for being of this Welsh Labour-led government. I'm proud that it is. We'll have a great deal more to do at the end of the coronavirus pandemic, though, because we will see harm that will have been unequally distributed across our country, and that's why the path to recovery has to take account of that and think about how we rebuild and remodel not just our economy, but the values that drive our choices. For example, the value we place on social care workers who will all applaud on a Thursday evening, but then to consider how much are we prepared to pay them, what do we expect them to do in caring for some of our vulnerable citizens, and what sort of society we want to build around that to make those choices possible.
Jane Bryant.
Diolch, Llywydd. Minister, earlier this week, BBC One Wales aired the programme Critical Coronavirus in Intensive Care. It was filmed by staff themselves in the Royal Gwent Hospital in my constituency, showing them working together in extreme circumstances with dedication, kindness and humour, expertly caring for patients with compassion. The struggles and challenges were there for all to see, working long shifts in full PPE, not being able to see facial expressions of those you're working with, and seeing so many people not able to pull through. It's difficult to watch, but the camaraderie and spirit shown by the incredible NHS staff is nothing short of amazing, and we owe them our deepest gratitude. The staff are under no illusions that in these difficult times, that it will end anytime soon. While in the Royal Gwent Hospital and in Iron Bevan University Health Board more generally, the numbers on ICU are back within their normal capacity, the concern over any further waves is most certainly there. What support and guidance can the Welsh Government give for those who've been at the front line of this pandemic for over 3 months to ensure that they have time to recover and are prepared for whatever comes next? And what assessment have you made of the needs of the workforce over the coming weeks and months ahead? And how can workforce planning reflect this?
Thank you. And I think it's completely right. I've obviously visited the Royal Gwent with Jane Bryant in her constituency on a number of occasions, and there are people who I know and have met on several occasions who work there, and I'm not surprised at all to see compassion, care and camaraderie reflected in the programme that went out. In terms of what we're doing, we're working both with the Welsh Partnership Forum that brings together the employers and the staff side within the health service to look at what happens in the future. It's a regular feature, one I'm really proud of. We invest lots of time, energy and effort in those workplace relationships here in Wales, and in particular in our health service. I've actually agreed to further fund the Health for Health Professionals service. We've tried that and we've rolled that out more consistently, so there's more practical support for staff who I know are finding some of the challenges that they have gone through on behalf of all of us difficult. And we shouldn't try to pretend that these people are able to simply carry on and on and on, working at the length of time they work for, with all of the challenge, the real difficulty that they see as well. So the scaling up of critical care capacity doesn't come cost-free. There is a cost for our staff that they have paid as well. And for me, in so many ways, it reiterates the importance of our stay at home, stay safe, stay local message, because the best thing that we can do to support those staff is to follow the rules. These aren't silly rules that have been thought of capriciously by a government that is doing something because it can do. These are serious rules to help protect the public, to keep more of us alive. And it's why we're in this position now, with a peak that reached earlier than initially expected, and less of a peak with less people having suffered real and unavoidable and permanent harm, including mortality, because of the rules the public have followed. And that'll be really important as we phase out of lockdown, for people to continue to remember that, because those staff need a break. And when we get into more stages of reaching past lockdown, people should not behave as if the world can be normal again and ignore social distancing rules when they're in place, because that will see more people going into those intensive care units, more pressure on our staff. And I hope that people consider that, not just on a Thursday when we're out applauding and cheering the NHS and key workers, when we go about our day-to-day business as well.
Sian Gwenllian.
Pa gefnogaeth ychwanegol fedwch chi I gynnig I wyddonwyr yn Mhrifysgol Bangor sy'n ymchwilio I lefela o'r feirws yn y rhwydwaith carffosiaeth? Nad ydy'r feirws yn heintus ar y pwynt hwnnw, mae modd defnyddio'r dull yma I fesur faint o'r Covid-19 sydd mewn dinas neu dref gyfan. Ac ydych chi'n cytuno y gall yr ymchwil a'r dull yma o fesur lefela Covid fod yn ddefnyddiol iawn ar gyfer monitro lledaeniad y feirws ar lefel lleol ac felly helpu I greu ymateb lleol wrth I amgylchiadau newid?
Yes, which is why I highlighted it in my press conference yesterday. I made specific mention of the research that scientists at Bangor University are leading on. And whilst we don't necessarily like to think about what happens with our sewage every day of the week, it is a really interesting and useful way to find out, and potentially at a much earlier stage, as you mentioned, of what is happening within each local community, within each local system, both to give an early warning of where coronavirus is on the rise, but also to give us a better idea, crucially as well, of if there's been a sustained fall off as well. So you wouldn't normally get excited about testing sewage, but this is a really crucial area of research for us. And if we're able to understand it at scale, then it can be really used not just in Wales, but across the UK. And I'm very proud of the work that Bangor scientists are doing with Welsh Water and United Utilities.
David Rees.
Diolch, Lewis. Minister, a couple of points. In your document, Test, Trace and Contact, Protect, it highlights the 10,000 has been already mentioned, and possibly up to 20,000.
Yeah.
But there's anticipation in that document that some of the gap will be filled by UK government type testing. As previously mentioned that the testing in England is 2 swabs, testing in Wales is 1 swab, and therefore they're not necessarily compatible in how they get the data into the Welsh NHS system. Are you now confident that that differences has been resolved, and that if you are using UK test based, the data will be able to come into Wales and work with the Welsh NHS? That's one issue. On care homes, can you please ensure that the advice from Public Health Wales is consistent with the guidance from Welsh Government? I have seen evidence from Public Health Wales which are telling a care home that even though they got COVID-19 in their home, it's an old situation and not current, and therefore they would not be tested. Now, after some arguments, effectively, we managed to get that home tested and the staff tested. But they have a sister home in the same town who are not being tested, and there are staff that will transfer between the two. Again, your guidance in Welsh Government says that's possible. Can you please ensure Public Health Wales follows Welsh Government guidance and gives that information out to the care homes? Because it is confusing for the care homes when we are telling them your guidance, Public Health Wales is not. And it's important, therefore, staff get tested.
Minister.
Thank you. On both points, if I deal with, I think there are 3 points, if I may, because on the data transfer, as I said earlier, that first point, that's been a key factor in being able to unlock that UK testing capacity in that system to come into Wales, because previously it would have been of much more limited value, but now I think we can make proper use of it. The difference between the 2 swab and the 1 swab test is the capacity that we've created here in Wales using the 1 swab test we'll still make use of, but we'll also now be able to make use of the UK testing capacity. Do we just need to make sure that it goes to the right lab? So, for example, the home delivery service will be taking advantage of and taking part in the UK-wide arrangements. That means those people only get a 2 swab test to self-administer, to return, and then that'll be tested in the appropriate lab to make sure we get the right results. So I'm positive about the fact we're not going to see significant problems in the way that's administered, but it's a fair point. And like I said, for me, the bigger issue was the data transfer. On your point about care homes, I spoke today with NHS chairs and chief executives, and I went through each of the health board areas about the position they're in with care home testing specifically. and I've asked each health board to make sure that within their local area, together with local government and their care home sector, that they provide a singular message within that local system about what testing is available and how to get hold of it and who to contact. So there's clarity within each part of the country, because it's not a matter that gives me any great pleasure to understand that there are anecdotal differences in different parts of the country. And I know that members are raising them because they're concerns that are being raised with them, but I'm more positive as we sit down now that real progress has been made over the last week, and that the wrinkles that I recognise do still exist in other parts of the country are going to be resolved. And I could not have been clearer about both my expectations, but the clarity in that message should, I think, give reassurance to yourself and other members across parties who want to hear that consistent message, and then, of course, the consistent implementation of it as well.
Lynn Neagle.
Thank you, Llywydd. Minister, I was very pleased to see the strong focus on mental health in your statement. You'll be aware that organisations like Hafal, Mind, and indeed the government's own suicide prevention advisor, Professor Anne John, have raised concerns about the impact of the pandemic on mental health. I'm pleased to see there is to be a COVID mental health monitoring tool. Can I ask you for some more detail on that? How, for example, will action be taken if there are any deficits or particular problems identified? What assurances can you give that support for those who are self-harming, at risk of suicide or in mental health crisis will be prioritised? And as we come out of this pandemic, I am confident that the mental health implications are going to be significant, and on that basis, mental health really must have priority with physical health as we plan to come through this pandemic. What assurances can you give that mental health will be just as a central consideration as we look to make those exit plans?
Okay, perhaps on the specifics, I think it might be helpful, because I think you'll want more detail than a 30-second answer. So perhaps if the member writes to me, I'll happily write back to the member and share that correspondence with other members as well on the details you have. I know that also means I'm asking for something, because I wouldn't be surprised if you managed to add more questions into the letter, but to give something in writing, to give the level of clarity and detail that I know you want to look for. Because to be fair, when we went through some of this at Children and Young People Committee, in terms of in particular children and young people's mental health, I know it's a consistent area of interest for you and the whole committee. So I'd like to give you a more comprehensive answer that can be shared and put into the public domain. And that must then lead to the continued work that we've done over a period of years in making sure that mental health is a priority. That's not just about the budget settlements where we put more money in, but the unfinished business of continuing to both deal with the stigma that still exists within the country about mental health, mental illness, but also then about the work that we do in terms of the parity of esteem in the way that the health service sees it as well, and then recognising how mental health and physical health are sometimes linked as well. So I'm really determined that when we come out of this, when we know there'll be more physical harm to deal with, but that isn't seen as the priority over and above mental health, but actually there's got to be genuine parity and understanding how we address those very real concerns. Because I say, all of us can probably point to areas in our own experience where we'd have concerns about people that we know, and that is very much the case in the constituents that we represent as well. So I'm more than happy to give that assurance, and I look forward to receiving your letter.
Finally, Dawn Bowden.
I just follow on from a question asked earlier by Angela Burns, because this week I had reason to use an NHS facility myself on a matter that was non-COVID related, and following a remote consultation with my GP, I was able to promptly get an X-ray, the service for which in my area has been transferred now from PCH to Ysbyty Cwm Conon for non-COVID related matters. And perhaps I should just take this opportunity to say a big thank you to all the staff there who welcomed me, and they treated me with the dignity and respect that I think has become the trademark of our NHS workforce. However, what I have to say that what surprised me was how empty the hospital was, and I'm sure there were people on the wards, but I expected to see a range of people in waiting areas who needed x-rays and other standard procedures, but that wasn't the case. And I know that you've stressed the need to resume a range of routine services, and you dealt with the issues around cancer in your answers to Angela Burns. But can I ask what practical progress is being made to get patients routinely back into the Welsh NHS so that we don't see this backlog of illness and disease? Because despite the messages that the NHS is open, if my experience at YCC is anything to go by this week, it certainly doesn't seem to be getting through.
Minister. Minister's
in a reversal
microphone.
of fortune. Excellent. Look, I share the concerns you have, because when I look at the figures and when I can see the fall off in activity for areas that are still open for business, we're still not at normal activity. Even in our front door services like A&E, we're still seeing people opting not to come in. And that concern that is leading to those choices being made is something that, in response to both Lynn Eagle's questions about recognising the mental health harm that can be caused by lockdown, there is, of course, physical harm potential where people are not coming in, but with urgent care needs. I don't believe the number of people who would have had strokes in the last 2 months has fallen off, but actually our activity over the last 2 months isn't what we would normally expect at this time of year. The same with other harms as well. So I'm really keen, which is why I want to come back with a further statement that will set out, when I've had those operational plans for quarter one from health boards, to sort of set out what more normal could and should look like to help rebuild the confidence of the public to make use of those services. Because I think without a regular restating of that we're not going to see a return to confidence or the sort of treatment that all of us would want for our constituents and indeed ourselves. And if I may, just at the end, Chloe, I hope that you didn't just have a good experience, but I hope that the member is now fit and well again following her recent appearance as a not-so-secret shopper in the National Health Service.
Thank you, Minister, and thank you, members. We'll be taking a short 10-minute break now, and we will pause the